for 3 to 1 year. So it may go for a little longer time.
Thank you. Doctor, you had a question. You had a question, doctor? Yeah, you please come.
So when we for cataract surgeons, we are very scared of getting holes inside the eye. Any viscoelastic inside the eye at the end of surgery. We take quite a lot of meticulous time to make sure that behind the IOL, in front of the IOL, sulcus, angles, everything is washed off. But I've noticed that most glaucoma surgeons say that this is a good thing to leave a little bit if you feel that it may overfilter. So what about the post-op inflammation? Do you see that there is more?
Cohesive, I have not seen much of post-op inflammation more, but HPMC I have seen. So I don't use HPMC. Once the cataract is done, then from behind the IOL and bag I will remove, and then in the AC I'll put Kohi, and while completing the surgery, and I try to wash off most of it, but sometimes I leave in Kohi back, so that immediate post-op hypotony won't be there.
And one more thing, the prostaglandin analogs, before you start surgery, do you shift over to any other thing, or is that?
Some people say, but I usually know. But I start Predfort 1 week prior QID.
Okay, so you don't normally stop.
Usually,
prostaglandin
when I opt for a filtering or a combined, the patient will be already on maximum medical therapy, and the pressures were maybe 30s or 40s. So I don't have a choice to withdraw PG analog, and anyway I'll be giving Diamox. So I start steroids and continue the prostaglandins. In postoperatively, intraop, if there was any complication, if cataract alone is considered, then maybe post-op I may have to change the PGA to some other AGM if it is cataract alone.
Okay, and one last question. Sorry. One last question. Would you do PI in a patient who's got less than 180 degrees sine K, but you're planning a cataract surgery? Would you do a PI anyway before that?
In an angle closure, I prefer to do a PI before cataract surgery.
Okay.
So that it will give some space and chance of getting an acute angle closure while waiting for the cataract surgery after dilatation may be also less.
Thank you.
Thank you, Dr. Manju. I invite our next speaker, Dr. Shaji Hussain. Dr. Shaji is a cataract and refractive surgeon practicing at Abate Eye Hospital, Perintalmana, and also he visits the Calicut Center. His topic will be cataract surgery in a compromised cornea.
Good morning, everyone. As you can see, the topic is about how to go about with cataract if you have a compromised cornea. So to begin with, the four main things wherein you have a compromised cornea before doing a cataract surgery, most of us would be facing a keratoplasty patient, a patient who has already undergone a refractive surgery, who is having Fuchs endothelial dystrophy and keratoconus. So the first thing to strike in keratoplasty is about the sutures. Remove the sutures, wait for 3 months, and then go about and do with your biometry. Refractive surgery, the two main concerns are which formula to apply and what IOL type to be placed in. In Fuchs endothelial dystrophy, it's definitely the grade and the count of the endothelium cells that's important. And in keratoconus, how smooth the cornea is. So to begin with, as I said, keratoplasty, remove the sutures, do the biometry. If it's already a hard cataract you're dealing with, better to go about with the small incision cataract surgery because less trauma to the endothelium. Now, let's say you are going ahead with in early stages. Usually, keratoplasty cataract is usually the patients are on steroids and the patient may be having usually most commonly PSC. So you're usually dealing with a soft cataracts initially. And here definitely it is the endothelial protection that has to be kept in mind. So you do quite and you have to use the dispersive visco. Make sure the rexus is well controlled. You can't afford to have an extension here because as such the endothelial counts and much of manipulations we have to be very careful here. Do a controlled rexus and then by making the incision make sure you are not involving the graft host junction. If you are a beginner you can always go with a sclerocorneal incision. and ensure you have a good, and when you're using the phaco, ensure you're using it in a low power mode. And next is to dealing with keratoconus. You have, as I said, you have to deal with see how smooth the cornea is and in what stage of keratoconus you're doing the cataract surgery. So in that, it is the formula that I'll be dealing with later. And the IOL, you can, ideally speaking, safer to go about with the spherical, but you have now toric and even high toric lenses that can be customized. Ideally, the available toric powers would be -6 cylinders, but if you can customize it, as in the previous speaker said, even up to 14 diopters and all can be after customizing it. So the con position, if it's central, you can go about easily, but if you have a decentered, then you have to counsel the patient accordingly. And post-surgery vision, you can never guarantee a 6/6 vision. It always depends on how much the patient will be seeing post-operatively only. And even while doing the surgery, the view is something you have to look at, because you may have excessive reflexes from the thin cone. If you are already dealing with a patient who's having an advanced keratoconus, it's ideal to go about with DALC and then do the suture removal, wait for 3 months, and then plan the cataract surgery later. If the patient develops a cataract later. If you already have an advanced keratoconus with opacity, you can even plan a triple procedure. With regard to the IOL, the standard approach is, if you go about with the normal formulas, there are high chances you can end up the patient in hyperopic surprise. And usually the patients prefer, after cataract surgery, it will be better to target a myopic power. So if you are dealing with a mild to moderate KC, you can always go about the SRK-T and keep a target myopia of -1 to -2 to be on the safer side. But if you are already dealing with a severe KC and you don't know what would be K would be, plan an SRK-T with a standard K of 43.25. And also now the Kane KC, Barrett 2 KC are all giving promising results, but it cannot be yet conclusively evidenced and not yet confirmed. So what is refractive surgery got to do with the formula? Here the main two things you're dealing with is the compromised anterior corneal curvature, and you know when a variation would result in a 1 diopter IOL, and the prediction, the difficulty in predicting what would be the effective lens position would be. So if you go about, usually if it's a myopic patient who has undergone a refractive surgery, you can always end up predicting an hyperopic shift. So the instrument error here would be in a post-refractive surgery, you know it is only the central zone that is being estimated, and even in the central zone in a post-refractive patient, you have different curvatures at different points. And the machine will be calculating it at 3.2 millimeters, but you know at the central areas, the curvatures are quite different. So again, you will be, in a myope, you will be underestimating the power and making him hyperopic. So what is all the trouble here is the refractive index being considered in all the IOL formulas are, it is 1.337.